Learning that a young man in a New York suburb has been partially paralyzed by polio is both tiresome and disturbing. Weary because it is the third highly contagious virus to abruptly enter the US in the past 3 years, following monkeypox and SARS-CoV-2. And shocking because polio hasn't been a problem for decades in developed nations, where immunizations, cleanliness, and good public health spending are intended to keep people safe. In the US in 1979, the entire Americas in 1994, and the UK in 2003, transmission was fully eliminated. However, it was found in the sewage of the young man's county and a nearby one, in London as well as in New York City. The poliovirus is what causes poliomyelitis, also referred to as polio. The poliovirus now results in a crippling muscle condition. And the central nervous system's extracellular neurons that produce this damage. The brain and spinal cord now make up the central nervous system. Motor neurons now innervate, or give tone and responsiveness to the muscles of the body, that stretch from the spinal cord. As a result, the muscles of the arms and legs are innervated. These motor neurons are now damaged by polio, which results in impairment. And as you can see over here, the man using the cane was once affected by polio as a child and has since suffered the effects of the disease's motor neuron damage. His right leg's muscles have atrophied, or to put it another way, they've lost muscular tone and have kind of shrunk up. Because they just shrivel away in the absence of any input from the motor neurons. Let's look back in time to learn how polio spread to the 2 cities mentioned before. Actually, there are 2 histories, one for the polio vaccine and one for how it has been used to eradicate the illness worldwide. Start with the vaccination formula, or formulas, as there are 2 of them if you will. Scientists Jonas Salk and Albert Sabin engaged in a fierce struggle that gave birth to them in the middle of the 20th century. The first formula to receive approval, developed by Salk, involves an injection to prevent the spread of the virus, but only an inactivated type of the virus. A few years later, Sabin developed a recipe that used a live virus that had been deliberately attenuated. It does prevent transmission, and because it is a liquid that children squirt into their mouths, it is less expensive to produce and simpler to deliver, because it doesn't require skilled medical personnel, or safe needle disposal. These characteristics make the Sabin oral version, often known as OPV, the major tool in the global eradication effort and the cornerstone of polio control. The oral vaccination has a special advantage. The true cause of wild-type polio is a gut virus. Before moving on to the nerve cells that regulate muscles, it replicates by latching onto receptors in the gut lining. Due to its location in the stomach, it also leaves the body through the feces and spreads to other people through polluted water. The Sabin vaccination benefits from that method. The vaccination virus multiplies in the child, passes through the feces, and protects the unprotected neighbors. However, that advantage hid a terrible drawback. The weakened virus occasionally returned to the neurovirulence of the wild form, killing those motor neurons and resulting in polio paralysis. A child that carried the reverted virus would likewise become more of a risk for infection than a shield due to that mutation. Rich nations abandoned the oral version due to this risk. When wild polio was no longer present in the US in 1996, the oral vaccine resulted in roughly 10 cases of pediatric polio paralysis. In 2000, the US made the move to the injectable medication known as IPV, and the UK did the same in 2004. Children are protected against both the wild-type and vaccine-derived strains of the poliovirus after receiving the entire course of polio immunization, which takes multiple doses to achieve. Therefore, the global immunization program kept using OPV, claiming that the risk would decrease as more kids received protection. When the initiative was young and health, officials believed it would take 10 to 12 years to complete eradication. That was a realistic risk to assume. It has been 34 years, yet the work is still not finished because of financial constraints, political and religious upheaval, and the COVID epidemic, which slowed down not just eradication efforts, but also all infant immunizations. While just 6 cases of wild-type polio occurred last year in 3 countries, there were a total of 688 cases of what is known as circulating vaccine-derived poliovirus paralysis in 20 different countries. However, by leaving type 2 out of the equation, there would be minimal protection against any type 2 virus that would resurface in the world, whether through an environmental reservoir or from a person whose body already contained a mutant vaccine virus. Additionally, the swap wager did not succeed. Svea Klosser, a medical anthropologist and associate professor at the Johns Hopkins Bloomberg School of Public Health who specializes in polio eradication, says, "I think the best way to describe this is as an honest error." They did not anticipate the scope and distribution of these type 2 outbreaks, or their worldwide reach. Most vaccine-derived viruses currently in circulation are type 2 mutants. The majority of its occurrences have been in Central Africa, where epidemics have crossed international borders. The type 2 mutant polioviruses were also discovered in New York and London. Importantly, despite the fact that these two viruses are related to one another and to earlier Israel-discovered vaccine-derived viruses, there is currently no genomic evidence to support their relationship to African viruses. They are more recent than the ones that are circulating in Africa because they have less genetic alterations from the vaccination virus. They most likely came from a place that either still uses OPV today or has in the past, like Israel did in the 2000s. According to certain research, type 2 has a distinct incidence rate with one paralysis episode for every 2,000 infected people. Therefore, if one New Yorker becomes paralyzed, thousands more could be unintentionally spreading the infection. The region can be more vulnerable than people realize if you take into account neighborhood clusters with low immunization rates. Due to the fact that episodes of polio paralysis only reflect the tip of an immunological iceberg, public health specialists view this as an emergency. At least a few hundred more people have probably carried asymptomatic infections than those who have been paralyzed, giving the virus a place to grow and spread. This requires time. According to wastewater analysis, polio has likely been spreading since February in London and for at least a few months in New York. However, health professionals were not shocked to see it return to Western countries. They have watched for years as budget reductions, vaccine reluctance, amnesia, and the virus's cunning nature have all damaged efforts to prevent the disease. Professor Heidi Larson, who founded the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine, asserts that this should be a wake-up message to individuals. "We have stated that until this is completely eliminated, everyone is at risk.